Good afternoon, everyone. You are very welcome to the HSE CHO DNCC Perimenopause and the Menopause webinar. The panel would be delighted to receive any questions you may have. Please use the Q&A feature located at the bottom of your PC or laptop screen. If you are using an iPad, you will find this feature located at the bottom of your screen. Your host for today's event is Cliona Kerwin, Health Promotion and Improvement Officer. Thank you.
Hi everyone, I'm delighted to welcome you today to our first webinar of our October series of webinars for Staff Health and Wellbeing Month. My name is Cliona Kerwin and I'm a Health Promotion Improvement Officer within Dublin North City and County. These webinars have been organised in partnership with the HR department and ourselves here in Health and Wellbeing. I'd like to introduce you now to Dr. Deirdre Lundy. Dr. Lundy has over 30 years experience in women's health, and she's the medical officer for complex menopause services within the National Maternity Hospital. Just before I hand you over to Dr. Lundy, I'd just like to make you aware that you can ask questions throughout the talk, and I'll try and do my best once Dr. Lundy is finished to get these questions to Dr. Lundy. So without further ado, it's over to you, Dr. Lundy.
Thank you very much, Cliona. I'm looking forward to this. I have to confess that I overbooked myself today, so I'm coming to you live from the breakfast nook of Buswell's Hotel, where Mr. Donnelly is launching the Menopause Handbook for GPs. And I can't get the Wi-Fi, so I'm working off my phone. And if I cut out, I'm really sorry, but you can always put your questions in, and if I have to come back afterwards, I will. We'll make another time. It's not a problem. So I'm going to go a little faster than I would normally go, just so we can get all the information in and hopefully get as many Q&As sorted out. So a little bit of background, first of all, before we start talking about menopause. Not everybody would know exactly what the process is. Even people with ovaries don't always know what's happening in those ovaries. So your ovaries are a serious part of your health. They're an essential part of your reproductive system. That's where all the eggs that you might eventually use one day are stored. They're also the source of multiple reproductive hormones, only a selection of which include 3 different types of estrogen, 1 type of progesterone, and the 4 different types of male hormone that the ovaries produce. But things are different for people with ovaries versus people with testicles. We all enter puberty around the same time. Our brains and our reproductive organs talk to each other with pretty much similar chemicals, similar molecules. But what's different about females is come the 40s and 50s, the ovaries start to decline. And they actually eventually stop releasing eggs and stop releasing hormones, which is something people with testicles do not experience. I mean, there is a little bit of a decline in hormone level, but they don't pack it in and go on a retirement holiday to Spain, which is what our ovaries do. Like even when you try to scan an ovary in an older woman, you can barely find the damn things. They literally shrivel up and almost die. And that can have a really big impact on our health, having gotten used to having hormones for 30 or 40 years and then having them pulled away from us. And it doesn't come without consequences. Now, thankfully, a lot of patients go through this transition from full ovary hormone to no ovary hormone kind of okay, pretty smoothly. But sadly, about 80% of us don't. And about 80% of us will notice problems. So the physical symptoms that can sometimes make you aware of the fact that your ovaries are no longer functioning properly would be things like flushes and sweats, changes in the quality and the length of your bleeds, changes in your vagina, changes in your metabolism, where no matter what you do, you keep gaining weight. You can start to notice changes in your hair and your skin and your joints. People who never leaked urine in their life before start to leak urine sometimes in the menopause. So, you know, it can be a bit harrowing. And if you Google menopause online, you often get images like the top left, but you got to remember loads of menopausal people look not witch-like, you know, so don't let that potential for symptoms make you frightened, because first of all, it doesn't tend to be severe for everybody. About 20% of people really, really struggle. The other 80% mutter through. The biggest problem, I think, especially when you seek help from doctors and nurses, are the emotional side effects, the emotional symptoms of ovary hormone decline. Because if you come in with irritability, anxiety, you know, rage, depression, sleep disruption, that kind of thing, people might understandably consider maybe this lady is depressed and needs to talk to a therapist and get some antidepressant medication, possibly. Whereas often those are the main symptoms of the menopause, and it does often go misdiagnosed and mismanaged, you know. So yeah, you can be itchy, grouchy, you know, psycho, whatever, but you can also look like my mom, who's 90, her next birthday, and was walking down Kalani Beach with me a couple of weeks ago, you know. So it's not all doom and gloom. It's absolutely, it's whatever you can make of it, the best you can make of your own health. So while it is a normal phenomenon, women in the developed world, women in the third world all go through menopause. It doesn't be cultural in any way. It does make an impact on the second half of our life, though, because we're living longer and longer and longer. So like 100 years ago, 200 years ago, people who went through the menopause died very quickly afterwards. So becoming older and aged was a natural part of being 45, 50, because you weren't going to live that much longer. Whereas now, women particularly are living well into their 80s and 90s. And we want to make sure that the quality of that second half, that second chapter, the health that we can enjoy is as good as it was in the first half. And it's not true for everybody. Some people have struggled with health issues their whole entire life. Things might actually get a little easier as they go past 45, 50. Sometimes they get much, much worse, you know. So you want to optimize the best you can. Within the workplace, we know that menopause transitioning people have enormous disadvantage. I mean, women often do, insofar as a couple of days every month we're, you know, troubled by menstrual difficulties, premenstrual syndrome, which can affect us in the workplace. But now we reckon that there's hundreds of thousands of people actively transitioning through menopause in full-time employment, including in the HSE. And it really, like, I've met patients in our services who had to give up full-time work or change jobs and home life completely because of the struggles and the strains of going through menopause, chronic sleep deprivation, mood changes, physical changes, brain fog. You know, it all has an impact on our day-to-day, including our work. So what can you do? What can you do about this? Well, some of it might involve hormone manipulation, and that's my area of expertise. I'm like a witchcraft supervisor for hormone replacement therapy, but it also involves just some common bleeding sense. And that's actually the hardest part of all of this. So optimizing whatever health advantages you currently have open to you is going to be the first step in this. Some people find over-the-counter OTC supplements useful, but I have to tell you, when you look at all the studies and the research, they're exactly the same as placebo, meaning if you take a vitamin, a multivitamin that has menopause in the title, and you feel better, chances are it's got nothing to do with the vitamin. It's because you wanted to feel better. That's called the placebo effect. And it lasts, but only for a couple of weeks. And after that, almost everybody goes back to how they felt beforehand. And it annoys me because some of those products are really, really expensive, you know? Some people will benefit from using hormones. Some people are not allowed, by the way. Most people are. But you need to know what your choices are so you can make the best decision for yourself. And make sure that your GPs and nurses are helping you out with that. Common sense stuff includes making sure you're eating well. I'm the worst culprit. I have 2 apples in my bag. That's going to keep me going until 7 o'clock tonight. I'm going to, that and caffeine is what I run on, and that's not healthy. I know this. So I've started to try to eat some porridge. I like tuna. I like salmon. So I got the oily fish covered. I think everybody should be on vitamin D supplements, and they don't have to be fancy ones with menopause in the title. Just get the cheapest one you can get your hands on. You need at least 400 units a day. So what I do is I take a big red pill. You can buy them. You need a prescription for them, actually. and they do the whole month because I'm so crazy I wouldn't remember to do something every single day. Calcium is important for women, especially as our bones start to decline as we get older. And especially if you're on bone drugs, you've got to be on calcium. But ideally, if you're fit and you eat dairy and you're active, you probably get enough calcium in your diet. You wouldn't necessarily need a supplement. Regular exercise is essential. Now, not everybody can run marathons, nor should they. But the WHO suggests that if you can find a half an hour a day, or do it in two days a week or 3 days a week and do an hour and a half, you're going to have a healthier life. You're going to feel better, generally speaking. You're going to live longer, and the years you live will be healthier lives. It's a no-brainer. It prevents cancer, it prevents heart disease. It's like extraordinary. It should be prescribable like medicine, but everybody has to tailor their exercise for their capacity. So I love walking. I love hill climbing because I can. My joints are healthy. I inherited that from my mother, and I have no chronic pain situation, whereas a lot of people, they can't do that kind of stuff. Or even if it's just doing exercises from a chair or going for a swim if you're a happy swimmer, but move. I heard a cardiologist talk recently that while you're at the kettle, which apparently is where we spend a lot of our day, do squats or stand on one foot. Any movement is better than no movement. Weight management is a lecture in itself. We are no longer allowed as GPs to look at somebody with overweight or obesity, living with overweight or obesity, and say, you should be exercising more, you shouldn't be eating bad foods, all that McDonald's, that is in the bin. Overweight and obesity is a chronic medical condition, no more than having diabetes is. And how we eat, the volume of food we need to satisfy us is as much a part of us as our eye color. Doesn't always tally with how much exercise we're doing. So if you are struggling, as I have done my whole life, with overweight, excess weight, talk to your GP. There are new therapies emerging to help you improve that. The same is true for alcohol. There are people who don't drink to the point of alcoholism, but actually have such a high regular consumption that it can have an impact on their health. And we certainly know breast cancer is linked to people who drink more than 2 units of alcohol a day. That's just a big old self-pour of wine. So that's an important issue. And lastly, smoking cessation. Obviously, if you haven't started smoking, don't. It's a nightmare. It's harder to quit smoking than heroin, and it does so much damage. And yet more and more young people are smoking than ever before. I was driving down my neighborhood the other day, and I just noticed so many people were smoking, picking the kids up from school, because they don't smoke in a house anymore. And that'd break your heart. And as you know, I saw the quit.ie program mentioned on the HSE. That's an amazing initiative, and we recommend it in general practice all the time. Sadly, when it comes to non-hormonal, non-prescribed therapies for menopause, there's not that much out there that is actually proven effective. I mean, everybody could try something and feel better, and that's absolutely cool, but it doesn't mean that it worked. It could mean that you made yourself feel better. Now, I'm all for that, whatever gets you through. But if you're looking for something that's going to give really strong benefit to your health and your symptom control, it's not going to be found on this list, okay? And some of these products are actually potentially quite dangerous, like St. John's wort, which a lot of people took for mood, used to be available in Ireland over the counter, and you can buy it online now. And don't get me wrong, it really does help mood, but it also interferes with the breast cancer drug tamoxifen. So you got to make sure you're getting good advice from somebody if you're going to use a non-hormone therapy. And now to talk about hormone therapy. If your thyroid was misbehaving and you were not creating enough thyroid hormone to feel healthy and be well, your doctor would automatically give you L-troxin, which is thyroxine, which is thyroid hormone. The same applies to the ovaries. If the ovaries are starting to falter, one way to kind of smooth out the ups and downs of menopause is to give hormone therapy, and that's exactly what we do. Now, not everybody wants this stuff, and that's absolutely fine. But I think some of the people who deny themselves at least a trial of it do so out of fear, particularly fear of breast cancer, which is unwarranted. So I just thought I'd put a few slides together to talk about that stuff, So like I say, we always talk to patients about, if your other hormones were packing it in, you'd take a supplement, you wouldn't think twice about it. Why are people so afraid of HRT? And I think in part it's to do with breast cancer. So about 20 years ago, there was a big study published in the Journal of the American Medical Association that wrongly, in their editorial, connected using HRT to developing breast cancer, implying that the one thing made the other thing happen, which absolutely does not happen. That is not the case. But breast cancer is scary because it is the commonest cancer after melanoma for women in the developed world. And one in about 10 of us, 1 in 9 of us is going to get it if we live long enough. You know, it's quite common. Now, most of those ladies will be 60 or 70 or 80. It'll be in later life. But everybody knows somebody with breast cancer, and the treatments are vile. Like, the treatments actually can make you feel worse than you ever have in your life before. So it is something that people want to avoid at all costs, and I fully get that. But there is no causative link between hormone therapy and breast cancer. Hormones don't cause cancer. The sun can cause cancer, benzene can cause cancer, cigarette smoking can change healthy cells into cancerous cells, HPV, viruses, oncogenic viruses sometimes create cancer. Hormones don't do that. But if you're unlucky enough to have pre-malignant cells in your breasts, and those cells have hormone receptors on them, and you now put extra hormone in your body for long periods of time, it's going to have an impact. But the impact is not as dramatic as you might think. Loads of things have been shown in research studies to have a connection between doing one thing and getting breast cancer. And some of them are completely goofy. Like, there's a famous American study that showed a 4-fold increase in breast cancer among African-American ladies who used an electric sleeping blanket. Like, that doesn't make any sense at all. That clearly the one thing does not make the other thing happen. But there is a connection between HRT and getting breast cancer. And this is the factual data that we have to work off at the moment. So when we're over 50 and the HSC calls us up to go for our mammogram, women between 50 and 60 have a 23 out of 1,000 chance of being told, uh-oh, I think we found something. You might have a malignancy in there. If you've been on HRT for at least 4 years, nothing happens in the first 4 years, and you're over 50, 54, 55, your personal risk goes up to 27 in 1,000. So that's 1,000 women over 50 who've been on HRT for at least 4 years. So instead of 23 in 1,000 chance of being told you have breast cancer, you got a 27. So you'd look at that and you go, well, Jesus, I don't want anything extra that's going to put my risk of breast cancer up. I get that. But look at the risk that you choose to accept if you drink more than 2 units of alcohol a day. That's worse than the breast cancer one. And look at what I live with being overweight. It's more than double, more than double. If you have excess weight after your 50th birthday, you have doubled your risk of breast cancer. So that's a really important comparison. Look at what physical activity does. So people who are fit and active, God bless them, actually have 7 less chances of being diagnosed with breast cancer for every 1,000 ladies. So it's not all about hormones bad, breast cancer. No, there's a lot of conversation that needs to be involved. So we offer it to anybody who's eligible. You can always try it for a couple of months and see if it makes any difference to your quality of life. And if it does, that's it, job done. If it doesn't, you stop. Another thing you have to remember is you're not just a head with 2 breasts connected. You have other organs in your body. You've got a heart, you've got a brain, you've got bones. And we know that women who use hormones for symptom control, who start it young in life, actually derive enormous benefit in cardiovascular health for as long as they stay on the hormones. The tricky thing about them, though, is they need to stay on the hormone to get the benefits. So if you use HRT for a few years and then you come off because you feel good again, and that's usually what happens, sadly, you've lost that cardiovascular disease protection. So some women will elect to stay on HRT possibly longer than they really, really need it, because their main goal isn't just to feel better and get over the hump of the menopause, but to also get some heart protection. And there's even a document telling doctors how to roll that out. But the key to this is timing, okay? You need to, I'll go back to this, you need to start your estrogen to prevent significant blockage in your coronary arteries before significant blockages take place. And that for women is usually 55, 60. So you can start HRT over 60, some women do, but the benefit to the heart will probably be not significant at that point. And who we are very keen to talk to are women under 40. Nobody under 40 should have a lack of estrogen in their blood, because that puts their heart at enormous risk, as it does their bones. So bone is a living organ. It's constantly changing, replenishing itself, melting down damaged bone, rebuilding new bone, and it's active, and it relies really heavily on estrogen to get that job done. And when your estrogen levels to falter and then drop, you notice that your bone mineral density goes down as well, okay? So that's a big problem for some people who've had early menopauses or surgical menopauses or doctor menopauses, where your drugs that you take for your cancer give you menopause, or they took your ovaries because of endometriosis or something. So we have to watch the bones of women who go through menopause, particularly when they go through those menopause phenomenon early in their lives. The loss to life and health and well-being with osteoporotic fractures is almost incalculable. And a lot of women won't survive a hip fracture, especially if they don't have good recovery and social care. So when we can prevent osteoporosis or delay osteoporosis, that is our main focus. And again, HRT does that. And the nice thing about HRT is you don't have to get it in like before the damage. You can use HRT as both a treatment and a preventative therapy for osteoporosis or osteopenia. So we do use another reason to give HRT, by the way, like official reason, is symptom control or for the treatment or prevention of osteoporosis. And significant improvement in reduction in fracture and fracture mortality is seen within a few months of starting HRT. So to summarize, and I know I flew through this, but I'm half afraid of losing the internet, and I'm also half afraid of somebody coming in and serving breakfast to somebody. If you think you might be starting the change, you probably are. Can you be starting the change and still have periods? Oh, yes, you can. And that's in the new handbook that Minister Donnelly is launching in the other room. You need to get some information ahead of time, because some GPs are extremely knowledgeable. Their nurses are trained up. Everyone loves the menopause. And some people, they're a little bit intimidated by it in healthcare. So you might not know which GP you have. So they're your first port of call, but maybe get some reliable information in your own head, first of all, so that you can go in and have a meaningful conversation. I actually think looking at people's websites, GP websites, is a good way to know who's women's health friendly versus not. Obviously, if you've got outstanding lifestyle issues that need to be addressed, do what you can for that. Psychotherapeutically, I think women carry a lot more responsibility than maybe we're even aware of ourselves. We overbook ourselves like I did today, and then we explode, and that's hard. It's hard to not want to help, because that's really what we're all about. Help the kids, help him, help in the workplace. Sometimes we need to help ourselves. And the first thing you can do is do what I didn't do this last 2 weeks, which is be kind to yourself and be happy to say no with a smile from time to time. I'm really sorry, but it's just a little too much. These are some very reliable websites that you can get wonderful information for your own sake on. And none of these are price barriered, so they're free to everybody. Like the ICGP handout, the launch today, that's only accessible to GPs. And I was asking the college people, like, what the hell? Why didn't you put that on the ICGP website? Why can't patients? Why isn't it on the HSE website? Why isn't it on NWIP or, anyways. Yeah, bigger brains than mine, the way. So that's all my slides. I hope that whirlwind run through menopause was enough for your lunchtime enjoyment. And I'm more than happy to ask questions, Kalina. So I'd like to know if you want to come back on, or I'll stop sharing anyway.
That's great, Dr. Lundy. Thank you for that. That was a real whistle-stop tour. I hope everybody got something from that. So
I'm good. I got 42%. We're good for the day. Oh no, you froze. Did I freeze or did you freeze? Oh, sugar. Uh-oh. I think I'm okay. Can you hear me?
Yes, we can hear you, Dr. Lundy.
Okay. I couldn't hear Kalina, and Kalina froze on me there for a minute.
I can come in there for a moment. There was a lot of questions that came in. Could you talk a little bit more, Dr. Lundy, about some of the different types of HRT that are available out there?
Okay, so when HRT was first invented, it was extracted, the hormones were extracted from the urine of pregnant horses. They call Premarin is a drug, that's a drug name, and it stands for pregnant mare's urine. So the original HRT was actually animal products, like insulin. Like years ago, insulin used to come from pigs, and we would take pig insulin and put it on our body. People still kind of do that with HRT in some countries, but we're trying to move away from that as much as possible. My figuring, and other experts' thinking process is that's good for menopausal horses, but we would like to put hormones in our blood that are as similar, or if not identical, to the estradiol, the estriol, and the estrone that comes out of a natural human ovary. So what has happened in the last 20 or 30 years is more innovation has taken place in the HRT pharmaceutical industry. So now you can get HRT products that have molecular structures that are identical to the best quality HRT. Has a drug in it called 17-beta, BETA, estradiol. And if you use your HRT estrogen as a patch or a gel or that spray thing that goes on your inner arm, those are all what they call body identical or ovarian identical 17-beta estradiol. So that is the gold standard for estrogen. And I wear a patch myself. Now, it doesn't suit everybody. Some people get itchy from the patches, or they don't want to have a patch. They want to try something else. You can get oral estrogen, and it's not the horse's hormone anymore. You can get oral estradiol. The difficulty there is whenever you put estrogen in your mouth, whether it's the contraceptive pill or HRT estrogen, it has to be processed in your liver. And in the liver, it can change the way the blood clotting proteins perform. So women who are already at risk of blood clots, these would be heavy women, smoking women, sedentary women, women who had a blood clot, say when they were pregnant, shouldn't really use HRT through the mouth. They should only ever use gentle low doses through the skin. When you wear estrogen on your skin as a patch, or you spray it in, or you rub it in as a gel, doesn't go through the liver initially, doesn't affect the clotting proteins, and it's neutral. Now, you could still get a blood clot. We could all get a blood clot, but it's not going to make your risk go up. The progestogen aspect of HRT is slightly more nuanced. So there's about 5 different progestogens that you can get in Ireland to use as part of your HRT cocktail. Now, and they're all good, they're all acceptable. There's only one of them mimics the molecule of the ovary, and that's called progesterone, O-N-E at the end. That's what I use. It's lovely, and I take it as a tablet, and it doesn't have any effect on blood clot. It actually helps me sleep, which is a bonus. The problem with it is, first of all, money. It isn't cheap. Second of all, the whole purpose of progestogen when we add it into HRT is to make sure that you don't bleed too much, because estrogen generally thickens the lining of the womb, and it can make you get a more bleeding.
Sure. Heavy period,
Yeah, so what we want to do is give you all the benefit of estrogen without starting a tsunami of periods. But Utrogestan, that really healthy progesterone, it's very weak. So a lot of people do bleed through. So other women will say, you know what, I'm going to get a Mirena. Mirena coils work as progestogen and HRT, and their contraception too, which is cool. You know, you might use another tablet of progestogen with more power to it to control your bleeding. And this is where HRT prescribing becomes more witchcraft than science. But that's why you want to go to a knowledgeable GP or nurse, you know?
Sure. That's great. Thanks so much, Dr. Cliona, you might have some more questions.
Sorry, if you lost me there, I don't know if you could hear me. Sorry about that. Just my internet connection. So just, Dr. Lundy, I don't know if you heard me just ask about the screening services that women should try and avail of.
So I take everything that's out there. So I do my breast check regular. I've started giving poo samples because I'm over 60 now, so I get to do the bowel health. I'm going for my flu vaccine. I already got my over 60s second booster of COVID. So if there's something out there that you're eligible for, jump on it. Cervical screening. I'm actually going to pay to get my mammograms done beyond my age of public health screening. And I don't know that I'll bother with the smears. I might do with the smears, but generally cervical disease is a disease of your reproductive life. So if you hit 55, 60 and you haven't developed cervical cancer at that stage, you're probably not gonna. The only thing is it is oncogenic virus linked. So if you get a new sexual partner in your older life and you're exposed to an oncogenic virus, maybe not having been so before, you could theoretically get funny smears in your 60s and 70s, but it's very uncommon.
Okay, that's really useful. And just to let our attendees know that we do have a screening talk on the 12th of October, just so if you want more information, you can sign up for that talk.
Yeah. There's loads of them. Like there's a prostate screening program, but I don't avail of that. So, you know, I wouldn't have knowledge on everything.
Yeah, they're so important, aren't they? So just going to run through some of the other questions. I think this is kind of an important one. Advice when someone goes to their GP and he or she is kind of dismissive of your symptoms when maybe you're a little bit younger, and how to deal with that. Have you any advice in relation to saying
that? That happens all the time. And that's actually one of the things that got me involved in training and education, because there are rules. There's actually guidelines and websites, and I do these courses for doctors and nurses constantly. And it's like, not everybody seems to read the book, like it's not rocket science. And the sort of the golden rule of menopause is that you don't have to be finished bleeding. You don't have to be post-menses to get symptoms. And most of my patients are in their 40s. Most of my patients are still getting periods, sometimes bang on every 28 days. You should never be dismissed as, you couldn't be in the change. And I think I blame gynecologists. So gynecologists use the word menopause very narrowly. They use the word menopause to say this is the last day of the last natural period a person ever has. So that if you're 55 and you haven't bled for over a year, you are post-menopause, meaning you're done. And if you were to start bleeding at this stage, it's cancer until proven otherwise. So it's a gynae term, is menopause. Mm-hmm. Whereas the symptoms that come with ovary decline officially is not called menopause by gynecologists. They call it the climacteric, which is insane. So I think the gynecologists should change their terminology. I think they should discuss women as being pre-menstrual or post-menstrual, menstrual or post-menstrual, and that we can adopt the word menopause not to mean the end of periods, but the beginning of the change. You're supposed to call it perimenopause, meaning I'm getting menopause-related symptoms, but I'm still getting periods from time to time. So I don't know how unless you hit them in the head with Minister Donnelly's launched guidelines, I really don't know how you can wake up some healthcare providers to actually read the rule book. But you could always say this, Deirdre Lundy says, because I swear to God, if they haven't heard of me already, they will do soon. Yeah. And I do free online accessible education for GPs all the time. There's no excuses.
That's great. And it's great to have those guidelines actually as well. If we could link those in the chat, that'd be great.
Yeah, I think that ICGP will have it and the HSE might have it as well.
Okay, brilliant. Just another one on HRT. There seems to be a lot of questions coming in on HRT. Should it include testosterone as it's not routinely prescribed?
Yeah. So when we go to the expert meetings, that's all we talk about. Because Davina McCall and some of the other sort of media types have been banging on about their testosterone. And don't get me wrong, I do prescribe testosterone all the time. I don't use it myself. I got enough ADHD. I don't need anything else working in my brain. But the guidelines at the moment are quite restrictive. So basically, estrogen and progestogen for anybody who walks in the room, within reason. Obviously, breast cancer is a little bit more nuanced. That's a no-brainer. But the only legitimate official reason for somebody to replace the testosterone that the ovaries make is low sex drive. So if you've noticed, as many women will have done, that in addition to the flushes and the sweats and the mood and all the other 7,000 things, you're actually just not motivated to have sex. And when you do try, you're finding it difficult to reach arousal and orgasm. They call that hypoactive sexual disorder. It's just low libido. That actually responds really well to testosterone supplementation. So that's the official reason for it. And GPs are supposed to be able to do this, but they weren't trained back in medical school and they're all frightened of it. The other thing we find is a lot of women who use it for sex drive notice that their brain fog improves, their exercise tolerance goes up, their joints are less uncomfortable. Now, it's not officially made for those problems, but I have a lot of patients who will ask about it really for that reason. So some GPs might say, well, hang on, that's not a legitimate reason to prescribe it. Only low sex drive is. So I say to my patients, so have low sex drive. Like, you don't know, you just say that. And then the rule of thumb nowadays, they've made it very restrictive. They've said you must measure the blood levels of testosterone in a candidate first. So you need a blood test, which normally we don't do blood tests in menopause consultations. Make sure they don't already have too much testosterone knocking around in the first place. Nobody does, but that's the rule anyway. And then you can use testosterone. Now, there's two kinds of testosterone. There's a crazy expensive stuff that's made for ladies going through menopause that comes from Australia. Costs you about 120 euros, not covered by the medical card, not covered by the drugs payment. Or you can just go out and get a box of male testosterone and use it in tiny, 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 tiny doses, which is what I would normally do in Holland Street, because people are not made of money. And say you try it and it doesn't work and you don't like it. You don't want to be stuck with a whole big box of testosterone. Some pharmacists are really helpful. They'll actually just dispense 4 sachets instead of 28 in a box and charge you equivalent, so that you can just play with it at home and see if it makes any difference. Like some people, it's a game changer, and other people, so you got to suck it and see sometimes. Yeah. But it's more nuanced. Like if you're just about coping with menopause in general practice, don't expect lots of testosterone chat, and we rarely use testosterone alone. We would usually use it as the icing on the cake to estrogen and progestogen.
Okay, so would I be right in saying, like, for anything, it's very personal, like what might work for somebody might not work for someone else. So
and this is the problem, in general practice is on its knees. I don't have to tell you that. There's not enough doctors out there for the capacity we need to care for our people. And that's just the way things have been going over these last 30 years.
Yeah.
So they like things that are simple. If you have diabetes, you are now covered by the chronic illness scheme. I can give you a half an hour of my time. I'll get adequately compensated for that. I have a big tick box of all the tests I have to do and all the information, but I'm not going to ask you which diabetes drug you want, because there's only a couple of them out there. Whereas with HRT, there's so much patient-doctor conversation, it frightens some people.
Yeah, that's totally understandable. I just see a link there to the screening talk. If anyone wants to join, you can click on it in the chat box there. You touched on some of the lifestyle factors there, but someone also just was looking to see what your views were in relation to weight gain and HRT. Would that be quite common?
Yeah. So menopause brings metabolic changes, and on average, people with ovaries between 45 and 55, if they don't change their diet and they don't change their exercise output, will probably gain between 1 and 2 stones. That's a given. So because your basal metabolic rate actually goes down. So the food you eat, you no longer burn. Now, I never have. Like, I'm very active, and I wouldn't have said I ate that much, and I tried to make healthy choices. My whole family is overweight or obese, and it's really been a lifetime struggle, So now the HSE and general practice has started to look upon this burden as what it is that, my satiety centers are not the same as other people's, and I don't exercise enough to be able to burn off the food that I eat, and menopause only makes that worse. Now, unfortunately, HRT will not make you drop weight. You'll sleep better, so you may not sit there with a bar of chocolate and a glass of wine because you're too tired to sleep, but it's not going to make you drop weight. That's for damn sure. But there are new strategies for weight control that don't include flying to Turkey for gastric bypass, so I'm actually playing myself, don't tell anybody, with this off-label diabetes injection, which is going to have a license in Ireland next year. So basically, it just controls appetite. It doesn't change my blood sugars. I don't get it doesn't make you diabetic. Yeah. But I just don't eat as much as I once did, and I can see a difference already. So, and that's just one of many strategies your GP can help you with. But again, you got to pick the right GP.
So I think that's really important, just to be aware that your basal metabolic rate will reduce. So it's just to be aware maybe of what you're eating and trying to really, really monitor that.
But it's easier said than done. Like if you haven't slept more than 2 hours a night solid for a year, 2 years, you're just dragging yourself through your day. And the only thing that keeps you going when you're exhausted is sugar.
Yeah.
So like, I have huge compassion for people who cannot make the better choices, because I've lived that experience myself.
Yeah, absolutely. I think you went through this in your presentation, but there are 1 or 2 questions coming in about alternative treatments as opposed to just HRT.
So some stuff we use and embrace. So I run a special clinic in Holland Street exclusively for patients for whom the rule book says don't give them HRT. It's certainly not in general practice. So about 50% of my ladies have had breast cancer. So those women are often naturally menopausal anyway because of their age, or they're menopausal because the radiotherapy, the chemotherapy, and the adjuvant therapy, the tamoxifen, the aromatase inhibitor, have just knocked them to their knees, creating menopause for them. And sadly, the thing I know will fix them, the estrogen, I'm not supposed to use. So we have been playing around with loads of other therapies. Cognitive behavioral therapy and mindfulness, either guided or self-guided on the internet, is a game changer for a lot of people. So if you haven't done that already, very much have a look at that. The GPs in Ireland have HSE funding to refer patients to an online service called Silver Cloud. I use it myself. And it's not like the only form of CBT mindfulness, but it's actually quite good. So that's one thing that I can recommend without hesitation. If you've had cancer, contact ARC Cancer Support. They're amazing for helping you with CBT access and mindfulness. We use a lot of a drug called oxybutynin. Oxybutynin is a medical therapy you take if you have overactive bladder. I don't know why, but it turns off flushes and sweats, and it works almost as good as HRT. So if your main problem is you can't sleep because you're waking up dripping wet 5 times a night and you've had breast cancer or you don't want HRT, you don't have to worry about that. We can help. There are some other drugs. GABA is a mood drug that we use. It's a chronic pain medication. It's not fabulous. It can actually give you brain fog, but it does help you sleep, and it does kind of even the mood during the daytime. Some improvement with flushes and sweats. But sadly, things like Dong Quai, black cohosh, evening primrose oil, and those vitamins, do it. I mean, do it. See how you go. But when we read the research on it, it's not very positive. No.
Yeah, that's really interesting because CBT wouldn't have been the first thing that I would have
It's
thought
number
of.
one.
So
yeah, do you know what it is? It doesn't change. It changes your perception of flushes and sweats. It really does. So like, I don't know if you've ever had a flush or a sweat. I hope you haven't, but I used to get them gangbusters, and like they start kind of around your kneecaps, behind your knees. And it's this kind of vibratory, tingly sensation, and you can feel, and it starts to rise up your legs into your pelvis, your trunk, and up to literally to the top of your head. And it's like everything is burning, like nettles have stung you. And then the sweating starts. And the sweating is here, and the sweating is here, and your armpits are stained. And you could legitimately think you're having a stroke or a heart attack because it's a whole body experience. Now imagine that happens 20 times during your working days and 6 times during the middle of your sleep. With the mindfulness, you learn to, first of all, recognize the phenomenon. This is my estrogen doing this to me. My ovaries are doing this to me. And then you kind of lean in to the flush and the sweat. So instead of the extra layer of panic that can often happen with that whole body sensation, you're like, hello, pick up the nearest makeshift fan and say, hello, vasomotor flush. I'm very happy to see you today. I'm not going to panic. Do what you have to do. And then I would say to the room, having a little flush, everyone take a moment, and feck them. Just have your flush.
Yeah. Absolutely. That's come in actually, hot flushes at night, any remedies, but I think you've answered that maybe with the CBT and trying some of the
the oxybutynin really helps if you're not a HRT candidate. Obviously common sense things like, layered, they make a sheet now that it's almost like period pants. It's like a special sheet that wicks away moisture. So you're not changing sheets and bed linens and stuff. Yeah.
Okay. Really interesting. I think you might touch this as well, but can you take HRT if you're on tamoxifen?
Generally, it's not recommended. So our first it should work because the tamoxifen fills the breast receptors with tamoxifen and should block the estrogen from doing any development, but at the moment it's not a permitted strategy. But like when you come into one of these specialty services, we don't take anything off the table. We try to be kind of responsible about it and try non-hormone therapies first. And I have to tell you, 99 times out of 100, it gets the job done. We don't have to turn to HRT. One thing you most certainly can use, by the way, if you're on breast cancer tamoxifen, is vagina estrogen. I never even got to say the word vagina. It's so unlike me. So in addition to all the other symptoms, the vagina changes as you go through the menopause, and some people really suffer. And the most effective way to fix those problems is by putting vaginal products of estrogen in the vagina. And thank God those ones don't have any link to breast cancer, either future risk of being diagnosed or survivorship or recurrence or death rates. So if your vagina is a bit of a dumpster fire and you need vaginal estrogen, you go and take it no matter what kind of disease or past medical history. That should be over the counter. And it actually now is in the United Kingdom. They have a product called Gina, I don't know, Gina, that you can just buy vagina estrogen that you put in yourself. Don't talk to a doctor.
Okay, that's really useful. Another quite specific question: how long should you take Femostan under 50 years old, and when should it replace the patch?
Yes, so Femostan is one of those good oral pills. It's not horse's urine. It's estradiol, the good estrogen, but it is oral. So if you're slim and fit, if you've no particular risk factors for blood clots, and your heart is healthy, why not just take a pill? I prescribe it all the time. I used to do in general practice. Now I typically see people who've got big health problems, so I probably don't use as much of it. But I would usually suggest by about 55, this is for healthy, happy, heart healthy people. 55 is a good watershed for the cardiovascular system. So by that age, if you're going to stay on HRT, and that's your choice, why not? I'm 61. I've been on it for the whole duration. You want to start looking at non-oral estrogen, because as you get older, your age becomes an independent risk factor for blood clots, thrombosis, pulmonary
increased risk as you get older.
And then like if you're 42 and you're like hugely overweight and you do smoke the odd cigarette, don't be on Femostan, go on one of the gels, patches, or sprays. So it's not like the pill, like people who would never give the contraceptive pill to, which would be heavy smoke and people over 40. All those ladies can try HRT if they want, but they should stick to the quality products.
And this question kind of runs into that as well. You said there that you're still taking HRT, and is there a cutoff for age limit? Like, should you stop after 60 or?
No. So the British Menopause Society are actually very supportive about stuff like that. They're like, the choice to use it at all is individual. So you either want it or you don't, unless you've got a cancer that puts a roadblock in your way, but we can get around that. We can talk around that. And then as far as how much to use and how long to use it, that's entirely up to the woman, the person herself, themselves. So we would usually say the worst of the symptoms usually improve somewhere in your early 60s. So theoretically, I could start to wean off at this stage. And I have toyed with the idea of going down. Rather than stop, I would just use less of the estrogen. You keep the progestogen the same always, but I would just use less of the estrogen, and then maybe skip from time to time until I didn't even notice I didn't have it anymore. And that's what most people do. And that's a personal choice. But when you do that, your bones start to slide, your brain your heart certainly starts to slide. Brains we're not too sure about. We know that there are some kinds of dementia, like vascular dementia, whose the risk is reduced by long-term HRT use, but we're not sure about Alzheimer's. I wish to God we could find a way through Alzheimer's,
Yeah, absolutely. And this is quite a specific one as well, but it may be quite an important question for this person. She says, I had estrogen positive breast cancer at 45 and got ovaries removed. Is there anything to remedy this?
Yeah, so you'd be the ideal candidate for one of these complex services, which we're supposed to have 6 of. Can you hear me? Yeah. Can you still hear me? Yeah, okay, because my thing went unstable. We're supposed to have 6 of countrywide, and there's actually only 2 of them up and running. The Rotunda service starts next week, thank God, so there'll be a 3rd one. So if you're in my catchment area, you can ask your GP to send you to my Hollis Street clinic to be brought through your options and choices for, medicine, strategies, whatever, having had breast cancer. The problem is if you live in Galway or if you live in Cork or somewhere, your services aren't available yet, and you're going to have to go private to get to a private menopause expert to get some advice about that stuff. Now, some GPs are amazing. Like I have a little group that I'm part of. It's a Telegram, like WhatsApp, only it's bigger. And I have 832 colleagues, Irish GPs, currently subscribing to that, where they say, oh, I have a lady with ER positive breast cancer and she's suffering with terrible sweats or flushes or vaginal. What can I do? And then we immediately give them a reply. So some GPs are amazing. You just have to make sure you're lucky enough to have one of those. And that's easier said than done.
Okay, I think that will be really useful for that person because maybe she didn't know where to turn to, but your complex services sound great. Another question about histamine. How does histamine help the menopause?
Yeah, I have to confess I'm a histamine moron. I don't know anything about histamine. So the Dr. Louise Newson in the UK is a very well-known menopause specialist, kind of like, she's like the me of England, and she's very involved in histamine intolerance or mast cell activation syndrome, which is an emerging condition. People didn't really know what it was heretofore, and it are just people who are very atopic, people for whom their own body chemicals, external forces can cause a lot of inflammatory response. Those patients typically get a very severe menopause that does not respond as well to menopause hormones as other people's. I don't know that much about it. What I know from Dr. Newson's side is that it's all about antihistamines, but we don't offer that service yet in Hollis Street, partly because we don't know what to do. Once the British Menopause Societies or the International Menopause Societies embrace histamine intolerance as a sub-cohort and give us guidelines, we will start to accept patients in that cohort as well. But there's no guidelines out there yet.
Okay, thank you for that. You mentioned the Mirena coil there, but this question is in relation to the Mirena coil. Can you take HRT with the Mirena coil?
HRT is always estrogen and progesterone if you have a womb. If you have no womb, you just use the estrogen. But if you have a Mirena coil inside of you and it's been in there for less than 5 years, there's still enough progestogen on that coil to balance the estrogen of HRT. So you don't need to take any other progestogen. Now, what happens if it's 5 years? What happens if it's 9 years in there or 6 years in there? You don't have to get a new one. You could, but you could leave the other one there because it's keeping your periods controlled or it's managing your contraception, whatever. And then now you have to take the progestogen either as a tablet or a patch or whatever. You just use extra progestogen. The Kyleena coil, the copper coils, the other coil, they don't apply. Only the Mirena coil, and only a Mirena coil that's been in you for less than 5 years would be enough to protect the lining of your womb from the estrogen and HRT.
Okay, that's really interesting. Thank you. I'm just going to go into the other questions here in the chat. I think you kind of covered this, but I think probably it's, anyone that's going through the menopause or perimenopause, how to deal with those menopausal symptoms during your working day.
I think being noisy is probably the first step. So being shy doesn't get us anywhere, as you well know. And instead of, admitting that you have a vulnerability, I may not be as attentive in a meeting or comfortable in a meeting or, behind a desk because I'm having this, to hell with that. They're lucky to have us in their workplace. And if we have a small, minor, medical condition that they need to embrace, well, so be it. So atmospheres should be kept cool. You can always put a hoodie on. You cannot take your bra off. They have objections to that, You should have a desktop fan. And if it wrecks the feng shui of the office, it's too bad about you. But I think that has to come from HR. It has to come from you as the menopausal staff members, but that's easy for me. I have no filter. I'm from New York. I totally get it that if you're not that person and you don't want to draw attention to yourself and you don't want to become like the menopause advocate in the workplace, ideally there should be strategies in place. And there are companies that give HR groups advice about how to have a menopause friendly work environment.
Yeah, it just must be so hard for people that are trying to get on with their normal day. I
it's
can't
like,
even imagine.
It's freezing in here. Karen's opened the window again. Sorry if your name is Karen, but you know what I mean? That's not.
We might just do one more question because we have a couple of minutes before our last slide. It's absolutely flown by, and I'm sorry that if I didn't get to all the questions, but
we could do it again.
Yeah, we can do it again. Can a menopausal lady get pregnant if she uses estrogel and HRT?
Yes. In fact, when I meet younger menopausal women who want a baby, the first thing I do is put them on high dose, good quality HRT to improve their fertility. So HRT is not contraceptive and it may actually enhance fertility. So you must use contraception if you're under 50 and you've seen a period even in the last 18 months, there's a good chance. Now, your fertility is not optimal at 49, but pregnancies have occurred, and they happen a lot. We see it in the termination data. We see a lot of older women coming in for medical termination. And I think it's because they thought they couldn't get caught. And obviously the body wants what the body wants, you know? So unless you know yourself to be fully post-menstrual, which is not the same as post-menopausal, you need contraception. Now, it could be a condom. You know, it doesn't have to be a Mirena coil, but you need to talk about that with your GP as well.
I just might finish on one final one. I think you've kind of covered this, but I think it's probably really important, because if there is somebody who has kind of complex issues in relation to their menopause and symptoms, you mentioned there, like, to get referred to yourself in Hollis Street.
So ours is a secondary, it's a secondary referral service, meaning it's like you can't just ring up Hollis Street and book a gynecologist. You can do that in a private hospital sometimes. You most certainly cannot do that in a publicly funded hospital. There's like a kind of a hurdle, and the hurdle is your GP. Moreover, because we have limited capacity, it's only me and Nicola, and we have one nurse. You know, we can't, at the moment, I got a 6-month waiting list for women who've had breast cancer treatment or people who've had a heart attack or whatever. And that's not fair to them, because the demand has outstripped the supply already, and we're not even a year in business. So we have a very limited protocol. So you can't just say, oh, my HRT doesn't suit me, I want to go see Deirdre. It does not work like that. On the Hollis Street website is a sheet that everybody can read, but it's there for GPs. We will only take patients who have a personal history of breast cancer, you know, ovary cancer, blood clots, heart attack, stroke, HIV, sickle cell disease, you know, that kind of thing. And then everybody else, it's back to the GP. Or a private menopause specialist if you have the wherewithal, which not everybody does.
Dr. Lundy, I think we're going to have to leave it there. We could chat to you all day, and that was the limit I could get through today, everybody. I hope that has covered a lot of the questions that came through, and we'd just like to say thank you so much for your talk today.
My pleasure. My pleasure. It was fun. I'm just glad my battery lasted and the computer lasted and everything, you know?
Absolutely, absolutely.
I'm running down Kildare Street. I go see my menopausal patients now in my Tuesday clinic. So thanks you everybody for giving me your time. And thanks to the girls from IMS. Bye. Bye-bye.
Thank you. Hey everybody, just in the last couple of minutes, I'd just like to remind you of our next talk, which is on Thursday, the 6th of October, and that's on domestic abuse awareness. So if you wouldn't mind, you can scan this QR code to sign up for this talk. I'd also just like to let you know about the remainder of our talks. We have a number of talks throughout October, and the links are going to be popped into the chat function there. So there'll be a link there to sign up. We have talks on dementia, screening services, relaxation and self-care. So after today's talk, that might be one that you might want to sign up to. We also have a talk on heart healthy, mental health, and employee assistance program also. You will be getting an email with the talk that's been recorded today. You will also be getting an email as well with a survey on today's talk. So we would be delighted if you could complete the survey, and you will be in with a chance to win a prize at the end of the week. The survey will also be popped into the chat function also. And I'd just like to say thank you, and hope everyone enjoyed the talk today.